Hello, it is my pleasure to discuss with you tailoring adjuvant therapy for early stage HER2-positive breast cancer after neoadjuvant trastuzumab and pertuzumab. My disclosures are here. As we have participated and developed clinical trials optimizing the adjuvant management of patients with HER2-positive disease. Certainly the work started with chemotherapy, then evolved to the addition of trastuzumab. But over the last 3 years, there have been 3 significant approvals in the early stage HER2-positive setting that have relevance to the discussion of today. First, there was the approval of naratinib for patients with early stage breast cancer, again, HER2 positive. And this was approved for patients who had completed 1 year of adjuvant trastuzumab-based therapy. Then, in 2017, there was the approval of trastuzumab pertuzumab. And in that setting, this combination of anti-HER2 agents was approved in 2 settings. Number 1, as neoadjuvant treatment for patients, again, with early stage HER2 positive breast cancer, and also received full approval by regulatory agencies as adjuvant treatment for patients who had already had surgery for early stage HER2 positive breast cancer. And third, in 2019, there was the approval of TDM1 or Trastuzumab Emtansine as adjuvant therapy for patients with HER2 positive early stage breast cancer who had residual invasive disease after neoadjuvant taxane and trastuzumab-based treatment. So how does that fit into the discussion today? Well, since 2013, with the accelerated approval, and then with the formal full approval of trastuzumab pertuzumab as part of neoadjuvant therapy, many patients, actually most patients, we recommend whose tumors are initially greater than 2 centimeters or who present with non-positive disease are managed with chemotherapy as well as trastuzumab pertuzumab. So what are the data of management of patients who do not achieve a pathological complete response after trastuzumab pertuzumab and chemotherapy? Well, that's where the data from the Katherine study come in. And this is the study that evaluated the comparison of trastuzumab in red versus TDM1 for patients who had invasive disease-free survival after neoadjuvant chemotherapy and anti-HER2 therapy. As you see from this particular slide, which has been discussed at previous venues, the use of TDM1 led to an improvement in invasive disease-free survival compared to trastuzumab with a hazard ratio of 0.50, highly statistically significant. And in addition to the hazard ratio, there was an absolute improvement of 11.5% possibility of invasive disease-free survival. Of note is that not all patients were cured, as at the 3-year time point that there has not been a follow-up report. The invasive disease-free survival for the intent to treat population was 88%. So 12% of the patients have developed invasive relapse to this point. And if one looked at the invasive disease-free survival for patients with no positive disease, it was 83%. So essentially, this data told us TDM1 is better than trastuzumab in this setting, but there's still work to be done. However, since the original Katherine data were presented, there have been some exploratory analysis of clinical interest that I would like to briefly discuss with you. Number 1, whether trastuzumab fared well or was really inferior to TDM1 for patients with small tumors at diagnosis. By that, what I mean, patients who had primary small tumors but who had positive nodal disease. How about patients who had small amounts of residual disease? Patients actually who had an initial HER2 positive disease in the first biopsy, but then when they underwent the definite surgery for breast cancer, they had a change in HER2 status. How about the outcome of patients who developed CNS metastases at first site of recurrence? And also, what was the outcome of patients who had concomitant hormonal therapy in addition to TDM1? Well, as these data are so relevant to practice, I'm sharing with you this one slide that provides a summary of the subset analysis from Katherine, and these reports were provided in 2019, as well as just a few months ago in 2020. Number one, the invasive disease-free survival benefit of T-DM1 was consistent across all exploratory subgroups analyzed, including patients who had a small amount of residual disease after neoadjuvant therapy. And this is really very important for practice. Number two, T-DM1 should not be withheld in patients with HER2-negative residual disease at surgery. In other words, if a decision is made to administer chemotherapy and anti-HER2 therapy as neoadjuvant treatment based on a HER2-positive disease, the fact that the subsequent biopsy does not disclose HER2 positivity should not dissuade physicians from considering T-DM1. You know, one of the reasons for this, obviously, is that data have demonstrated over the years that after a patient is diagnosed with HER2-positive disease, they continue benefiting from anti-HER2 therapy, and it may be an issue of tumor heterogeneity. It may be an issue of the specimen that was obtained at the time of definite surgery that may be confounding potential interpretation. But again, based on Katherine, even if the tumor is tested to be so-called negative, it may actually not be really negative, and T-DM1 should be preferred over Trastuzumab. Number three, although there's a numerically higher incidence of CNS recurrences as first invasive disease-free survival event in the T-DM1 versus the Trastuzumab arm, it is likely due to a competing risk as the ultimate outcome of patients, if one continues with follow-up, is really not different. With longer follow-up, the rates of CNS recurrence are about the same for the two arms of the study. At the same time, it tells us, it's important that we focus on additional studies to decrease the risk of CNS metastasis. Overall, although not here, even if a patient has small primary tumor at the beginning, if they have nodal disease, but they still develop residual invasive disease, T-DM1 should be the recommendation. So overall, the Katherine trial introduced a new decision point in HER2-positive early-stage breast cancer, where the adjuvant treatment should be optimized based on the response to neoadjuvant therapy. So it's very clear based on the data that T-DM1 will be the preferred approach compared to Trastuzumab if there's residual disease after neoadjuvant therapy. And based on this data, Trastuzumab Emtansine, or T-DM1, has been recommended in this setting for multiple guideline groups globally, including NCCN, AGO, ESMO, as well as St. Gallen. One very interesting aspect of the St. Gallen guidelines, which I wanted to mention to you, is that in the St. Gallen guidelines originally, they said, well, T-DM1 is recommended for residual invasive cancer following either Trastuzumab-based or Trastuzumab-pertuzumab-based regimens. Again, pertinent to the topic of discussion today. What are the data that can help guide management of patients who achieve PCR? And before I go over the data of patients who achieve PCR, I would like to mention to you, although I did not include a slide, that in the Extended trial, and that was the trial that originally evaluated the extended use of neratinib after completion of 1 year of Trastuzumab-based adjuvant therapy, there was a subset of patients who received a neoadjuvant anti-HER2 therapy, and then they continued the year of Trastuzumab, but in half of the patients, they did receive an extra year of neratinib. And in the retrospective analysis of that subgroup, it appeared that using neratinib after neoadjuvant therapy without PCR also appears to decrease the risk of invasive disease-free survival compared to Trastuzumab alone. So it's a second set of data, although much more limited than the data that we have to T-DM1, suggesting that if a patient has residual disease after neoadjuvant therapy, the approaches could be TDM1, or also there could be a consideration of, a TDM1, even followed by neratinib, or TDM1 with neratinib, or even the combination of trastuzumab, pertuzumab, followed by neratinib, although I must clarify with all of you that we don't have any large prospectively performed randomized trials. If patients do not achieve an invasive, clear disease, or if the patients have residual disease at the time of definite surgery, really comparing TDM1 to TDM1 in combination with neratinib, or the combination of HP or trastuzumab, pertuzumab. So there are some gaps in knowledge. So if I can summarize this section, the first option will be TDM1. Other options are being considered as part of clinical trials. But now let me move to the patients who do achieve a pathological complete response after HP and chemotherapy in the neoadjuvant setting. Well, there are three hypotheses to consider for these patients. Well, the patients who achieve a pathological complete response could have, highly sensitive disease to HER2 therapy and may be cured after neoadjuvant therapy. On the other hand, these patients may still have microscopic HER2 positive clones remaining, and they need prolonged treatment for a total of 1 year to increase the possibility of cure. And that could be accomplished with the original dual HER2 targeted treatment that was used in the neoadjuvant setting. And the other option could be, well, this patient still have sensitive tumor to HER2 targeted therapy. They need some additional anti-HER2 therapy, but what might it be? Might it be trastuzumab? Might it be trastuzumab, pertuzumab? Might it be TDM1? Might it be neratinib? Or might it be new trials? So there is a gap in knowledge at this time, but at least I'll share with you our practice based on the trials that have been performed, as well as the new trials that are in development. The one trial that is in development, that actually is more than in development, it's already active for patients, is called the COMPASS study. And this is an example of other studies that are being conducted at the national and global level. But let me guide you so that you can appreciate the extent of research currently being done with the goal to help patients. If you look at the left side of the slide, this study is enrolling patients with HER2 positive early stage breast cancer, and the patients are being registered to receive chemotherapy, and the chemotherapy can be taxane based. The chemotherapy really can be based on weekly paclitaxel or docetaxel in combination with trastuzumab, pertuzumab. And then the patients undergo surgery. If the patients achieve a pathological complete response, the patients receive a year of trastuzumab, pertuzumab, with that additional chemotherapy. And to me, this is a really very important point, because in practice, the way I think about this is that if you have a patient who's deemed to be at high enough risk to warrant neoadjuvant therapy, and specifically to warrant a neoadjuvant therapy with taxane in combination with trastuzumab, pertuzumab, this patient, in spite of achieving a pathological complete response, is deemed still to be at high risk of recurrence. Therefore, my first choice of treatment would be to continue trastuzumab, pertuzumab. This is a little bit controversial. Some people are not as convinced as I am that is that approach. But again, using less than trastuzumab, pertuzumab in the setting of PCR would be based on a really lack of solid, if I can underline this data. But I can understand some of the thinking, because it's clear that if a patient achieves a pathological complete response, the patient tends to have a better outcome compared to patients who do not achieve a pathological complete response. However, one very important aspect for all of us is that achieving a pathological complete response does not mean that the patient is cured. Therefore, I believe that it's important for us to try to maximize anti-HER2 therapy, and that can be accomplished with a combination of HP, even in the setting of pathological complete response. But if we continue to look at the data, the data that are being used for the COMPASS trial, if a patient has residual disease, which is still expected to occur in about 60% of patients who receive chemotherapy plus dual anti-HER2 blockade, then the patients are actually being randomized to a couple of different options. Either the patient receives T-DM1, which is considered to be the standard of care as per our discussion a few minutes ago, or the patients are being randomized to receive T-DM1 with tucatinib. And I think this is a really a very elegant study to demonstrate if tucatinib, the small molecule tyrosine kinase inhibitor, can add to the benefit of T-DM1 in the setting of residual disease after neoadjuvant therapy. I should clarify to you that a trial is also in development evaluating DS-8201 or Trastuzumab deruxtecan, also in this setting, comparing DS-8201 to T-DM1. So it's very good that over the last few years, there has been a lot of interest in this area. There are good data to help guide our clinical practice, and there's some studies that will help us even further compared to where we are. So how do I view the treatment of patients with early stage HER2-positive breast cancer in 2021? Well, on the left side, we start with the patients who have small burden of disease at the time of diagnosis. So patients whose tumors are less than 2 centimeters or have clinically negative disease should proceed with surgery as first approach. If the patient is found to have a stage 1 disease at the time of this initial surgery, then I believe it is appropriate to consider treatment with weekly paclitaxel with Trastuzumab. So in this case, I would not use dual anti-HER2 blockade. However, if a patient initially presents with what appears to be stage 1 HER2-positive early stage breast cancer, and the patient goes to surgery, but then at the time of surgery, it is found that the patient's tumor is really stage 2 or 3, then as adjuvant, we should consider chemotherapy, which can be docetaxel based, it could be anthracycline based, with a combination dual blockade of Trastuzumab pertuzumab, understanding that most of the benefit of adding pertuzumab is for patients with a no positive disease. And in this particular setting, you could also consider, in addition to the year of starting with chemotherapy and then the full year of Trastuzumab pertuzumab, to add a year of neratinib, particularly for patients with hormone receptor positive disease. And particularly, it's also very important to start the neratinib as soon as there is the completion of the HP treatment. That would be consistent with the EMA guidelines for extended adjuvant neratinib for this patient population. If we go to the right side of the slide, which is the most relevant for today's short discussion, patients who present with a tumor that is at least 2 centimeters in size or present with clinically positive disease, in this case, our recommendation is for neoadjuvant chemotherapy in combination with dual anti-HER2 blockade. The patient then proceed with surgery. If a patient achieves a pathological complete response, we would consider HP as the recommendation. And in this particular setting, you would even consider an additional year of neratinib if the tumor is hormone receptor positive. And again, this is based on the data from the Extend study, as well as the understanding that not all patients who achieve a PCR are cured of HER2-positive disease. On the right side, if the patient undergoes surgery after neoadjuvant therapy and they do not achieve a pathological complete response, the recommendation would be for T-DM1 and potentially consider also the use of neratinib. Of course, clinical trials are also available. So overall, what we recommend for patients with early stage HER2-positive disease, if they have a low risk of recurrence, they get 1 year of anti-HER2 therapy. If the patients are deemed to have high risk of disease, we will consider extended adjuvant therapy even beyond 1 year with neratinib. And again, the decision of adjuvant therapy is tailored based on the response to neoadjuvant therapy based on the data I've discussed with you. As a last slide, there's remains a significant amount of translational research that is being done in the setting of HER2-positive disease, including further understanding of tumor heterogeneity, the microenvironment, downstream signaling pathways, as well as other membrane receptors and their ligands, all in the context of the potential role on the immune system with the idea of improving patient outcome. So on this note, I would like to take a moment to thank you for your attention. to do this COVID-19 situation. I cannot be there with you in person, but as with all of my talks, I always remember the reason that we all do this work is because our patients really are awaiting our continued improvements. And you see a picture that I had an opportunity to take last year with one of my patients, Donna, and her husband. And I continue to support the 26.2 with Donna Foundation. We have a virtual event the second weekend of February 2021. And I would invite you, all of you, to look up breastcancermarathon.com and join us in this virtual event to help raise funds for research, and most importantly, raise funds to help underserved women suffering from this disease. So on this note, thank you very much.